a burning sensation in the soles of your feet at night that makes sleep impossible. A tingling that travels up from your toes like an electric current running through wires that were never meant to carry that signal. A numbness so complete that the floor beneath your feet feels like you are walking on packed cotton rather than solid ground. If any of that is familiar to you, you are not alone, and you are not imagining it. Approximately 1 in 4 adults over 70 experiences some form of peripheral neuropathy, and the vast majority of them are managing it the wrong way. Not because they are not trying, but because the most important piece of information about this condition has not reached them. I am Dr. James Mitchell, and that piece of information is this. Researchers at the University of Utah conducted a study in which they took skin biopsies from patients with peripheral neuropathy before and after a structured exercise program. What they found under the microscope was not subjective improvement in symptom scores or patient-reported reduction in discomfort. They found actual visible regrowth of nerve fibers, new nerve endings growing back into tissue where they had previously been lost. This is not theoretical, it is not anecdotal. It is observable biological evidence that the right physical stimulus can reverse nerve damage in a way that most patients are never told is possible. Today, I'm going to walk you through 6 exercises organized into 3 therapeutic categories that replicate the protocol behind that research. You need a chair, 15 minutes a day, and the consistency to apply what I am about to show you. No gym membership, no specialist equipment. Nothing that requires you to leave your home or push your body beyond what it can safely tolerate. Before we get to the exercises, let me give you the clinical context you need to understand why they work. Your peripheral nerves function like insulated communication cables that run from your spinal cord outward to your extremities, carrying sensory information including pain, temperature, and positional awareness back to the brain, and motor commands from the brain outward to the muscles. When those cables sustain damage, the signal becomes distorted. Your brain receives noise rather than information, and that noise is what you experience as burning, tingling, pins and needles, or the frightening absence of sensation called numbness. The most common cause is diabetes, which accounts for approximately 40% of peripheral neuropathy cases. Chronically elevated blood glucose triggers a process called glycation, in which sugar molecules bind to nerve proteins and progressively impair their function. But the causal list extends well beyond diabetes. Alcohol directly damages peripheral nerve tissue and simultaneously impairs the absorption of vitamin B1, which nerves require to function. Vitamin B12 deficiency, which is more prevalent than most people realize and is significantly worsened by long-term use of metformin and certain acid-suppressing medications, produces a well-documented neuropathic pattern. Chemotherapy, autoimmune conditions, and obesity all contribute, and in approximately 30% of cases, even after thorough investigation, no identifiable cause is found. On the question of nutritional support, the evidence is clearest for 2 interventions. Alpha-lipoic acid at 600 milligrams daily has been evaluated in multiple rigorous clinical trials and demonstrated reductions in neuropathic pain and tingling of 30 to 50%. Vitamin B12 levels should be checked, particularly in anyone on long-term metformin. And one warning that I consider important enough to state plainly. Vitamin B6 in doses exceeding 50 milligrams daily does not help neuropathy. It causes it. Please review the B6 content of any supplement you are currently taking. Now, let us address what you came here for. The first category of exercise is cardiovascular movement, and I want to be direct about why it comes first in any evidence-based neuropathy protocol. The nerve fiber regrowth observed in the University of Utah research was attributed specifically to the cardiovascular component of the exercise program. Aerobic activity increases blood flow to the peripheral tissues, delivers the oxygen and nutrients that damaged nerve fibers require for regeneration, and stimulates the release of neurotrophic growth factors that signal the nervous system to repair and rebuild. The other exercises in this protocol produce meaningful benefits, but they produce less of them when the cardiovascular foundation is not in place. The general target is 150 minutes of moderate aerobic activity per week. Walking, cycling on a stationary bike, and swimming are all appropriate options. But I want to give you a specific exercise you can perform at home, regardless of weather or confidence on your feet, because both of those barriers are real for someone managing neuropathy. Sit in a sturdy chair with your spine upright and away from the backrest. Begin lifting your knees alternately in a seated marching motion, adding an arm swing so that the opposite arm moves forward with each knee lift. The pace should elevate your breathing noticeably without making conversation impossible. That is the correct intensity. Begin with 3 minutes and add 1 minute every few days, working towards sessions of 10 to 15 minutes performed twice daily. That delivers 20 to 30 minutes of cardiovascular stimulus each day, with a fall risk of essentially zero because you are seated throughout. The second category is balance training, and its clinical importance in the context of neuropathy is specific and serious. One of the neurological functions that peripheral nerve damage disrupts most consistently is proprioception, the body's continuous real-time awareness of where its limbs are positioned in space. When proprioceptive signals from the feet are degraded or absent, the brain does not receive the information it needs to make the micro-corrections that keep you upright on unpredictable terrain. The result is an elevated fall risk, and for adults over 60, a fall frequently means a fracture, a surgical procedure, and a period of enforced immobility that accelerates the very deterioration we are working to prevent. The first balance exercise is the single leg stand. Stand behind a sturdy chair with both hands on the back of it. Shift your full body weight onto your right foot and lift your left foot just slightly off the floor, no more than an inch. Hold that position. The initial target is 30 seconds on each side, but if 5 seconds is your honest starting point, begin there without apology. Perform 3 rounds on each side. As 30 seconds becomes manageable, remove one hand from the chair. When one-handed balance becomes steady, remove both hands. And when bilateral unsupported balance is reliable, close your eyes. That final progression is where the most significant neurological adaptation occurs. By removing the visual input that your balance system has been compensating with, you force the damaged proprioceptive pathways to take on more of the load. This is the neurological equivalent of strengthening a weak muscle by making it work harder. The adaptation is real and it is measurable. Most patients notice a meaningful difference within 2 weeks of daily practice. The second balance exercise is the heel-to-toe weight shift. Stand with your feet shoulder-width apart and one hand resting on the chair back. Slowly shift your weight backward onto your heels, allowing your toes to lift slightly off the floor. Hold for 1 second, then smoothly roll your weight forward onto the balls of your feet, allowing your heels to lift. Hold for 1 second. Return to the neutral position. Perform 15 repetitions for 2 sets, moving slowly and with full conscious control of every phase of the movement. This exercise trains balance, strengthens the calf musculature, and delivers repeated sensory stimulation to the mechanoreceptors in the soles of your feet, the receptors that are responsible for ground contact awareness, and that are among the first to be compromised by peripheral neuropathy. Every repetition sends a signal through the peripheral nervous system toward the brain. With consistent daily practice, you are reinforcing those pathways and encouraging whatever remaining nerve fiber integrity exists to work more effectively. The third category is direct foot and lower leg activation, and these exercises address something that happens in the periphery of the nervous system that most people with neuropathy are unaware of. The small intrinsic muscles of the foot, the muscles responsible for toe control, arch support, and the fine postural adjustments your feet make with every step, are innervated by the smallest and most distal nerve fibers. These are among the first to be affected by neuropathic damage and among the first to show atrophy when the motor nerve signals that maintain them become degraded. The following 3 exercises directly reactivate the neuromuscular pathways to these muscles and to the larger muscles of the lower leg. The fourth exercise overall is the calf raise. Stand holding the back of a chair. Slowly rise onto the balls of your feet, counting 2 seconds at the top of the movement. Then lower your heels back down over 2 seconds, controlling the descent and never allowing the heels to drop rapidly. 12 repetitions for 2 sets, with 30 seconds of rest between sets. The circulatory benefit of this exercise in the context of neuropathy is significant. The calf musculature functions as a venous pump. Each contraction drives blood upward through the deep venous system of the lower leg. Each relaxation allows fresh, oxygenated blood to flow downward into the peripheral tissues. For nerves that are struggling to regenerate in a chronically poorly perfused environment, this increased circulatory throughput represents a meaningful improvement in the biological conditions for healing. Additionally, each repetition delivers a proprioceptive signal from the foot through the entire peripheral neural pathway to the brain, providing the kind of consistent, repeated stimulation that encourages the nervous system to maintain and gradually restore those connections. The fifth exercise is the towel scrunch. Sit in a chair and place a thin towel flat on the floor in front of you. Position your bare foot on the near edge of it. Using only the toes, scrunch the towel toward you in a gripping, pulling motion. Spread the toes, grip the fabric, flex, and pull. 10 repetitions on each foot for 2 sets. I want to prepare you for what this will feel like initially, because the preparation matters. Your toes may respond slowly or imprecisely. The movement may feel disconnected, as though the instruction from your brain is arriving at the foot with a delay or a distortion. That experience is the clinical reality of what neuropathy does to motor nerve transmission, and it is exactly why this exercise is therapeutic rather than discouraging. Every attempt to activate these neuromuscular pathways, even imprecise and effortful attempts, sends a training signal through whatever nerve fibers remain functional. Over successive sessions, the brain is literally relearning how to communicate with these muscles through the available neural infrastructure. The movement becomes more precise. The response becomes more immediate. As a progression, replace the towel with small objects such as marbles or pencils and practice lifting them from one position to another. This advances the exercise into fine motor territory that challenges the peripheral neuromuscular system at a higher level of precision. The sixth exercise is ankle circles combined with the alphabet movement. Sit in a chair and lift one foot slightly off the floor. Rotate the foot in a full circle 10 times in one direction, then 10 times in the reverse direction. Move through the complete available range of motion at the ankle joint with each circle, slow and deliberate. Then, using the tip of your big toe as a pen, write the letters of the alphabet in the air. Each letter requires a different trajectory, a different combination of ankle and foot muscles, a different proprioceptive demand. This variability is the point. You are training the neuromuscular system of the lower leg and foot across a wide range of movement patterns rather than through a single repeated motion, which produces a more comprehensive restoration of the neural connections that neuropathy has disrupted. Let me give you the complete daily routine in a form you can apply immediately. The total time commitment is 15 minutes. Begin with the seated march for 5 to 10 minutes. This is your cardiovascular foundation, the component that drives nerve fiber regrowth by improving peripheral blood flow and stimulating neurotrophic factors. Follow with the balance section. Single leg stand, 30 seconds each side, 3 rounds. Heel to toe weight shift, 15 repetitions, 2 sets. This portion takes 3 to 4 minutes and directly addresses the fall risk that neuropathy creates. Complete the session with the foot activation exercises. Calf raises, 12 repetitions, 2 sets. Towel scrunches, 10 repetitions per foot. Ankle circles and alphabet, 10 rotations each direction per foot. This final section takes 4 to 5 minutes and directly targets the peripheral neuromuscular connections that neuropathy disrupts most severely. On days when you are able to walk outdoors, add 20 to 30 minutes of easy-paced walking. This supplements the home routine without replacing it. 3 clinical principles determine whether this program produces results or simply occupies 15 minutes of your morning. The first is graduated loading. If a set calls for 12 repetitions, begin with 6. If a hold calls for 30 seconds, begin with 10. Peripheral nerves respond to gradual progressive stimulus. They do not respond well to sudden large demands. Add modest increments weekly rather than pushing prematurely to the prescribed targets. The second is daily consistency. 15 minutes every day produces substantially better neurological outcomes than an hour performed once or twice per week. Nerve regeneration is a slow biological process that requires sustained, repeated stimulus to continue. Missing days interrupts the signal. The third is foot inspection after every session. When sensory nerve damage is present, the normal pain signals that would alert you to a blister, a pressure sore, or a small cut may be absent or significantly reduced. A brief visual inspection of the entire foot after each exercise session takes less than 60 seconds and prevents the kind of wound that can escalate to a serious problem in a neuropathic foot. I want to close by returning to where we began, because I think it deserves to be the final thought you carry forward. The researchers who took those skin biopsies and looked at them under the microscope were not reporting hope or optimism. They were reporting observation. Nerve fibers that had been absent grew back in tissue that had been treated with the right exercise stimulus. This is biology responding to a signal you have the ability to provide. The signal is not a medication. It is not a procedure. It is movement applied consistently in the specific forms that the peripheral nervous system responds to. Here is my challenge to you. Begin with the seated march and the single leg stand tomorrow morning. Add the remaining 4 exercises over the following week as each new movement becomes familiar. Practice every day without exception for 30 days. And at the end of that month, come back to this video and leave me a comment. Tell me your age, where you are watching from, and what you noticed. Which symptom changed first? When did the floor begin to feel more like floor and less like cotton? When did the nighttime burning begin to ease? Your account of that experience is not simply feedback. It is the evidence that someone else in this community, someone who has been living with these symptoms and wondering whether anything can actually change, needs to hear before they give up on the possibility that it can. Please speak with your physician before beginning this program, particularly if you have active foot ulcers, severe loss of protective sensation, or significant balance impairment that makes standing exercises unsafe without direct supervision. If you are on metformin or acid-suppressing medication long-term, ask your doctor to check your B12 level. And if you have not discussed alpha-lipoic acid with your physician, that conversation is worth having. If this video has given you something clinically useful today, please share it with someone in your life who is managing these symptoms, and subscribe to this channel for weekly medically grounded guidance made specifically for adults over 60. Peripheral neuropathy is not the end of the story. It is a challenge with a biological response available to it. You now know what that response looks like. I will see you in the next one.